So good afternoon and welcome to the ISN-KDIGO webinar. This is one of the webinars of the series on complement in glomerulonephritis. And specifically, the title of this webinar is What's New in the Management and Treatment of Glomerulonephritis, a look at IgA nephropathy and membranous nephropathy. And it's my pleasure to be the moderator of this webinar, which I believe will be truly exceptional. And my name is Marina Vivarelli. I'm a pediatric nephrologist, and I work in Rome, Italy, at the Ospedale Pediatrico Bambino Gesù. And I have a specific interest in the field of glomerular diseases, especially nephrotic syndrome and complement-mediated diseases. And the two speakers today who will be leading the webinar are Professor Heather Reich from Toronto, Canada, who will be speaking on IgA nephropathy, and Professor Vivekanand Jha from India, who will be speaking on membranous nephropathy. So I will briefly introduce both of them, and then I will give the floor to Heather Reich, who will start by talking about IgA nephropathy. So Heather Reich is a graduate of McGill University, Faculty of Medicine. She completed her clinical training and her PhD at the University of Toronto, and she is presently the Division Director of Nephrology at the Department of Medicine of the University of Toronto. She is a clinician scientist and holds the Gabor Zellerman Chair in Nephrology Research, and she directs the glomerulonephritis program at Toronto General Hospital. And she will be covering IgA nephropathy for this webinar. Following her talk, we will have Vivekanand Jha. He is the Executive Director of George Institute for Global Health, India, and the Chair of Global Kidney Health for the Imperial College in London. And he is also the immediate past president of the ISN. His research interests include understanding the health and societal impact of diseases, especially kidney diseases, throughout the world, conducting epidemiological studies and clinical trials. He has helped to develop global guidelines in glomerulonephritis and transplantation, chaired several kidney disease treatment guidelines for national health programs in India, and he is also an advisor to the World Health Organization. So I think the quality of the speakers today is absolutely exceptional. I'm very excited about this webinar, and I will collect all the questions, which will be taken by both speakers together at the end of both of their talks. So without further ado, let me leave the floor to Professor Heather Reich. Welcome and thank you.
Perfect. Thank you for the generous introduction, and from our meeting chair, thanks to the ISN and our sponsors for the opportunity to present today about what is new in the treatment of IgA nephropathy with a discussion focusing on complement. Here are my disclosures, and the long list reflects rapidly growing interest of the pharmaceutical industry in the field of IgA nephropathy. First, I'm going to present a case to guide the discussion and then review the best available treatment evidence to date with some recent updates. And finally, I hope to finish with a review of the role of complement in IgA nephropathy and the wealth of upcoming and current clinical trials in this area. So this is a fictitious case for anonymity, but quite typical of someone I would see in clinic. This is a 24-year-old woman born in China who moved to Canada at age 16. And she's noted to have hypertension when she sought medical care at a clinic for respiratory tract infection. She was referred to a nephrologist who found her blood pressure to be 160/90, creatinine of 89 micromoles per liter, likely large for her, high for her habitus, and proteinuria of 1.8 grams per day. And after starting her on RAS blockade, she underwent kidney biopsy and was found to have high-risk features, including mesangial and endocapillary proliferation, segmental sclerosis, and some crescents. And the first step in my care is in line with guidelines, and it would be to estimate the 5-year risk of having of GFR or kidney failure using the online international tool. And in this case, that's 20%, which is actually quite high. And so we're going to move to the question. So after optimization of blood pressure with diuretic and max RAS blockade, proteinuria is still 1.1 grams per day. What's your next step? Is it to add an SGLT2 and then decide? Is it to start corticosteroids or enroll in a clinical trial of non-steroid therapy? And the second question is, would this change if this individual was of Caucasian ancestry as opposed to Chinese born and Chinese ancestry? Wow, so split pretty even between SGLT2 and corticosteroids, and split right down the line about ancestry. Absolutely fascinating. Okay, so we're going to see if this changes after you've listened to the trial, to the rest of the presentation, pardon me. So our patient is at significant risk of progression, and we also have to consider her young age and ultimate desire to conceive. We also have to think about the concept of treating the disease and the immunopathogenesis versus simply adding protective strategies to prevent further deterioration in renal function. So according to the 2021 KDIGO guidelines, with co-authors sitting here as speakers on this panel, the first step in management would be to consider enrollment in a clinical trial, and then to consider the role of corticosteroids. The results of the testing study were published after release of these guidelines, and we can discuss whether or not this sequence should be changed once I review the results. So the testing study was conducted in 67 centers around the world. There were 503 patients with proteinuria over a gram a day who were randomized to receive either corticosteroids or placebo. And the primary outcome of interest was a composite outcome of sustained 40% reduction in GFR, kidney failure, or death due to kidney disease. Ultimately, treatment with corticosteroid was associated with a marked reduction in the risk of the primary kidney outcome. So the best evidence suggests efficacy of corticosteroids, but you will recall that the study was initially paused, and I just showed you the publication of part 2. The protocol was changed midway through the study because of signals of potentially avoidable toxicity in the patients who were receiving corticosteroids, specifically high rate of serious adverse events, which included PJP pneumonia, which was felt to be a preventable complication with the use of prophylaxis. So toxicity was certainly a concern, but even at the midpoint analysis or the premature analysis, there were already signals of efficacy which justified continuation of the study. And the low dose protocol adjustment went to 0.4 milligrams per kilogram per day of methylprednisolone, and PJP prophylaxis was offered in both groups to mitigate risk. Here, I'd like to draw your attention to the bottom 2 panels. They show the reduction in kidney endpoint in placebo versus methylprednisolone group. On the left-hand bottom left panel, we have the full dose protocol, and on the right-hand panel, we have the low dose protocol, and we see that the reduction in risk in primary outcome was significant in both protocols, and this reduction in risk persisted for a surprisingly long term after treatment was completed. So how do we reconcile trial results? Well, it's important to compare essential features of the cohorts included in each trial. Here, I'm going to show the largest randomized trials that we have to date in IgA nephropathy. First, we have the STOP study. As you recall, this was a study that did not find any benefit associated with addition of immunosuppression on top of maximal conservative therapy. We have the testing study, which I just showed you. And then finally, we have the nephroprotective subgroup analysis of the DAPA-CKD study that included the IgA nephropathy patients. So let's look at these three studies and why, what's important to take about the populations and take home from differences in cohorts in these studies. Firstly, by far, the testing study included the largest cohort. The DAPA-CKD was a large cohort, but it was a pre-specified subgroup analysis. It was not designed specifically to show efficacy in this cohort, but nonetheless was a pre-specified analysis. So let's look at race and ancestry. STOP IgA study was really Caucasian in ancestry, pretty much 100%. The testing cohort included a large group of patients of Asian ancestry. The largest subgroup of Asian patients were those of Pacific Asian descent, specifically studied and born in China. But there was a population of 4% Caucasian. And finally, DAPA-CKD was split between Asian and Caucasian individuals. So very different ancestry. And whether we take ancestry into account when we interpret results of studies is a very large question that we could spend hours discussing, but I'm going to leave that for your thought. Next, let's look at the age of the patients. So 6 years in difference in a study can have some lead time bias and can also create differences in the timing of in the disease activity. So for example, earlier in disease activity, there may be more inflammation amenable to immunomodulation, whereas later age, maybe later in disease stage where fibrosis might be the dominant picture. And there really is quite a clear age difference with the DAPA-CKD cohort. In terms of proteinuria, the highest degree of proteinuria at randomization was observed in the testing study, with ACR as the measure of proteinuria in DAPA-CKD of 900 milligrams. eGFR as well was quite different in the DAPA-CKD by definition. The annual GFR loss in the supportive group during the study period was very different between the STOP and the testing study. And we do see quite a rate of rapid rate of renal function decline in the DAPA-CKD study. I would say this rate was a little high considering that the patients had relatively low degrees of proteinuria. And finally, histology, really interesting results. Remember that histology, a biopsy is not always done exactly at the time of enrollment into the clinical trial. There may be differences. It may be an outer limit of 10 years required, but be that as it may, there were differences in the degree of mesangial and endocapillary proliferation, with much more proliferative activity seen in the biopsies of the subjects in the testing study. There were only a subgroup of patients in the STOP study with available biopsies, and here we did see fibrosis in both, but again, we see a little bit more of a sclerosis and fibrosis pattern as opposed to seeing, large degrees of mesangial and endocapillary proliferation. Very interesting, and whether this is driven by age, ancestry, stage of disease, biopsy practice patterns is something all to think about. In the DAPA-CKD study, this was really designed as a CKD study, not as a GN study. And so actually, we don't have any biopsy data from the study. There was no limit to the timing of between biopsy and enrollment. And in fact, 6% of the subjects had no biopsy. And it was the clinical suspicion of the clinician that the patient had IgA nephropathy. So there were restrictions in terms of the time from biopsy to randomization. Nonetheless, the vast majority of patients had biopsies within the first, had enrollment and randomization within the first couple years of the study. And the median time was 5 months in testing, 9.4 months in the STOP study. So here is a slightly modified version from a post-testing publication commentary that I recently had the honor to write with Dr. Flügge, who of course was the senior author of the STOP IgA study. And first you'll notice that DAPA is still, or SGLT2 inhibitors are still not the primary included in the primary list in the protective strategies. This reflects a couple of thoughts. First, the need to consider a treatment approach that fundamentally alters disease pathogenesis as opposed to nephroprotection. We don't know if we mask proteinuria by pushing SGLT2 inhibitors and RAS blockade. We don't know if masking that proteinuria, we may be missing underlying inflammation and progression of kidney injury that we are not treating. Second, the safety of concurrent use of SGLT2 inhibitors with high-dose corticosteroids, we still is not confirmed. We need to study this in more detail. You can simply hold the SGLT2 inhibitors during the period that the patient is receiving high-dose corticosteroids, and this would be to avoid theoretical risks of genitourinary mycotic infections or euglycemic DKA if the patients unknowingly develop steroid-induced diabetes during their treatment. There are some other important remaining questions here. We really don't know the relationship between race, age, baseline proteinuria, and steroid response. We're awaiting analysis from the testing group regarding pathology findings and responsiveness to corticosteroids. We don't know the lower limit of GFR where steroids or SGLT2 inhibitors will be effective. And finally, we have the emergence of targeted release budesonide, complement strategies, endothelin inhibitors, some new strategies where we're really trying to mitigate steroid toxicity. Here I would ask, are we still comfortable enrolling a patient in a placebo arm of a clinical trial and withholding corticosteroids? And I think that's an important question to ponder, and we can talk about that during the question period. With respect to budesonide, as you are likely aware, targeted release budesonide, now available under the name of Tarpeo from Calliditas, aims at addressing primarily the production of IgA by the mucosal-associated lymphoid tissue in the gut. And so it's a minimally absorbed corticosteroid. In this right panel, we see that there was a 30% reduction in proteinuria compared to placebo in their phase 2 study. The phase 3 study is in 2 parts. The first has a surrogate marker of proteinuria reduction, and it was this endpoint that allowed Tarpeo to receive accelerated and conditional approval by regulatory authorities in the United States. Part B is a GFR-based endpoint required for full approval. The data are not yet published, and we really eagerly await these data and results. Today we are discussing complement pathway, and of course, to avoid the toxicity profile of corticosteroids, we continue to search for new approaches that alter the pathogenesis of the disease. You are likely aware that complement can be activated by the classical lectin alternate pathway, and these ultimately converge. And rather than review the entire cascade, I'm just going to highlight some clinical evidence that complement is involved in IgA nephropathy. So here on the left, you can see that it's been known that the vast majority of biopsies demonstrate mesangial deposition, co-deposition of C3 with IgA. This has been known as far back as 1968, and at least 75% of biopsies are positive for C3, and C3 will also be found in circulating immune complexes. A second major finding that implicated the alternate pathway in IgA nephropathy is GWAS data that linked variants in complement factor H regulatory genes with protection against IgA nephropathy. The genes encode proteins that titrate the inhibitory activity of complement factor H. So the net result of this variant is reduction in synthesis of these proteins and tendency to dampen alternate pathway activation. That's associated with reduced risk of IgA. So conversely, the default physiologic constant activation of alternate pathway would support development of IgA nephropathy. So these reflect the ongoing efforts to study the role of inhibitors of complement activation in IgA nephropathy. Studies are as far along as phase 3 and inhibit several mechanisms of complement activation. They incorporate fascinating technology, including RNA inhibition, humanized biologics, and are even available in oral form. The endpoints on the right are largely proteinuria related, but ultimately all will require GFR endpoints for final approval. So we have RNA inhibitors, we have the lectin pathway, and a large focus on the alternate pathway of complement inhibition. These are preliminary results of the oral factor B inhibitor presented at EDTA. And as you can see here at the 200 milligram dose, there was a significant reduction in proteinuria compared to placebo at 6 months of treatment. This continues, these data continue to evolve as recruitment continues. But these data were sufficient to design the phase 3 study, and this is ongoing. These data are partially published and show reduction in proteinuria in patients who received a lectin pathway inhibitor in an open label and double-blind protocols combined. And we can see the reduction in proteinuria when these patients were considered together. There are, of course, ongoing additional approaches, including enhanced supportive therapies with endothelin inhibition. We have APRIL and BAFF axis manipulation as another pathway of therapy in IgA nephropathy. And so there's a lot of hope in terms of emergence of new therapies in IgA nephropathy, with particularly advanced efforts now in complement inhibition. And so I'm just going to finish with checking the results. We're going to repeat the same questions and see if anything has changed. A little bit less of the SGLT2, still split with ancestry. I like the need for, I like the clinical trials here and use of corticosteroids, and hopefully we can address some additional discussion during the discussion period. Thank you.
Thank you, Heather. That was absolutely stellar, and I'll hand it over to Vivekja now.
Sorry. Thank you very much, Marina, for the introduction, and congratulations, Heather, on that remarkable talk. Which is going to be somewhat hard to follow, but let me try. So what we will transition now from IgA nephropathy to membranous nephropathy, and once again, we will discuss a little bit of where we are with regard to complement of this condition. And here are my disclosures. Now, with regard to membranous nephropathy, it is fair to say that the current times that we live in was really, the clock was reset in 2009 with the publication of this paper that described the identification of M-type phospholipase A2 receptor as the target antigen in idiopathic membranous nephropathy. And most of what I'm going to discuss now will have some relevance with regard to this particular molecule. So let us start with a case. We have a 67-year-old man with mild hypertension on treatment with ramipril. His blood pressure is reasonably controlled and he has a BMI of 29. You can see the serum creatinine, which gives us an eGFR of 62. Serum albumin is low at 2.2 and the urine protein creatinine ratio is 5.6. The electrophoresis, immunofixation, ANA, C3, C4 are all normal. His anti-PLA2R antibodies are at 92 RU per ml, and hepatitis B and C serologies were negative. So can we bring up the poll, Eugenie? The question is, what is the most appropriate next step here? So can we have the first poll? What will you do? Here are the choices. You will do a PET-CT to screen for cancer. You will do a kidney biopsy, or you will start renin-angiotensin blockers, diuretics, and statins, or start immunosuppressive therapy. This is just to get a sense of what you guys are thinking, and there is no right or wrong answer. I think we can stop the poll and have a look at the answers, Eugenie. All right, very interesting. So 45% people will do a kidney biopsy in this person who had high elevated PLA2R antibody. And of course, 30% will start renin-angiotensin blockers, 14% will start immunosuppressive therapy also. And I can see that more than 10% will do a PET-CT to screen for cancer. All right, thank you. Can we move on? Yes. So now let's look at the antibodies to phospholipase A2 receptor antigen. And this has, as I said, represented a remarkable advance. And we have now two methods to detect these antibodies in circulation in individuals who are suspected to have membranous nephropathy. We can use indirect immunofluorescence, or we can use ELISA. And the specificity of the association of positive PLA2R and clinically correct case of membranous nephropathy is very, very high. And so that you can see in this the systematic review, which was published in 2014, the specificity in 15 studies was 99%. And you can see that indirect immunofluorescence test is more sensitive compared to ELISA, which according to the manufacturers is considered to be positive when the RU value is greater than 20 per ml. And so this hypothesis has been tested now in observational studies. And this is one publication from Dr. Fernando Fervenza, who looked at 5 centers in US and Spain, looked at both in individuals with PLA2R positive serology, 276 people, and who had also undergone biopsy. And so the cohort of those who had primary membranous nephropathy and biopsy and positive PLA2R serology combination was 101. And what they found is that the biopsy findings did not change diagnosis or management if the eGFR was more than 60. If the eGFR was less than 60, and then there was just one additional finding, which included a superimposed case of acute interstitial nephritis. So therefore, based on these kind of data, now the KDIGO 2021 guideline says that a kidney biopsy is not required to confirm the diagnosis of membranous nephropathy in patients with nephrotic syndrome and a positive anti-PLA2R antibody test. And so much so that if the GFR is more than 60, then even treatment decision can be based with this presumptive diagnosis. So once we have gone over the diagnosis part, the main treatment related questions that we always worry about is how do we identify who is at risk of adverse outcomes if they have membranous nephropathy, and how to develop a risk-based treatment approach. And the various things that we often worry about is the waiting period before starting immunosuppressive agents. The traditional teaching is 6 months. What are the different regimes now that are currently available, and how do we choose between them? How do we develop a monitoring protocol with the availability of anti-PLA2R antibody measurement and tailoring treatment duration? And again, we have learned a lot by understanding the immunological and clinical course of membranous nephropathy. And again, let me emphasize that this is specific to those individuals who have anti-PLA2R associated membranous nephropathy. We now know that in the initial period after the antibody is generated in the body, it is possible that all the antibody goes into the kidneys and gets deposited there, and nothing will be apparent in the circulation. So if in that phase, if the person undergoes a biopsy, you might find the antibody staining in the glomerulus, but circulating antibody levels might be absent. When the kidney stops absorbing the antibodies that are produced, they start making their appearance in circulation and become detectable in the serum. And after a while, the patient develops clinical proteinuria and in most instances, a nephrotic syndrome. Now, after some time, either spontaneously or as a result of treatment, the disease may undergo remission. And you can see that the first thing to fall is the circulating antibody level. And this is followed after some time by reduction in proteinuria. So immunological remission precedes clinical remission after some time. And this is something which is really important for us to understand as far as the longitudinal monitoring of this particular antibody is concerned. So let's come back to the case. This patient was followed up at 6 months. This person, this of course was followed up, but was started on angiotensin converting enzyme inhibitor. At 6 months, edema persists, but it does not limit this patient's daily life. The serum albumin has increased to 3.8 and the proteinuria has decreased by 50%. The GFR remains stable. The anti-PLA2R levels have progressively dropped to 18 RU per ml now. And remember that the cutoff for positive is 20. You can see that the proteinuria has dropped, but hasn't disappeared. So again, now another question that I have for you is, what would you do now? You think that the patient has achieved immunological remission and will likely have a clinical response. So nothing else needs to be done at this particular point of time. But the second option is that you think that the person continues to have proteinuria, so we should continue to treat with rituximab. Or the third option is that you want to go ahead and treat the patient with cyclophosphamide and steroids. All right, very interesting. A majority of you think that the patient has achieved immunological remission, and so nothing needs to be done because clinical response will follow. But a minority feels that we should treat the patient with rituximab since proteinuria persists, even though the anti-PLA2R level has fallen to less than 20, and a smaller proportion think that we should give cyclophosphamide and steroids. All right, let's go back to the slides. So this takes me to the practice point made by the most recent KDIGO guideline. And the point is that we should realize that immunosuppressive therapy is not required in patients with membranous nephropathy unless they have at least one risk factor for disease progression or unless they develop serious complications of nephrotic syndrome. And what are those risk factors? So those risk factors are eGFR value, the degree of proteinuria, and then there are a few other risk factors which are used in certain centers but are not in widespread use. For example, the measurement of urinary alpha-1 microglobulin beta to alpha-1 microglobulin beta to microglobulin, urinary IgG, and proteinuria selectivity index, etc. But I think what has now become in widespread clinical use is the use of anti-PLA2R level. So clearly, people who have life-threatening nephrotic syndrome or exhibit rapid deterioration of kidney function, which is not otherwise explained, would be considered to be at very high risk of developing adverse outcomes, and they will perhaps require treatment straight away. Whereas the high-risk group will also require treatment, but we have greater options in deciding what kind of treatment you want to give. But moderate risk is the group of people where we can, again, continue to wait and see. And so based on this, this understanding, the recommendation says that in patients with membranous nephropathy and at least one risk factor for disease progression, we recommend using rituximab or cyclophosphamide and alternate month glucocorticoids for 6 months, or CNI-based therapy for 6 months, with the choice of treatment depending on the risk estimate. This is extremely important. I think in the recent times, you would all agree that most of the literature in membranous nephropathy has been dominated by clinical trials that have utilized rituximab. And I won't go into individual clinical trials, but just summarize this evidence, which was nicely done by Professor Pierre Ronco when we were discussing this during the development of the guidelines. So what we have learned so far is that we can get clinical remission, both partial and complete, if we use cyclophosphamide and steroids in up to 85% patients thus treated. Rituximab clinical remission is associated in slightly smaller proportion of individuals. Cyclosporine alone, a relatively low rate of clinical remission. And if you use tacrolimus along with rituximab at 6 months, as was used in the Starman trial, about 60% of individuals go into remission. If you focus only on complete remission, cyclophosphamide and steroid by far gives you the best results, 35 to 60%, including trials done by us. Rituximab, 35 to 40%. Cyclosporine alone, hardly any one goes into complete clinical remission, whereas tacrolimus and rituximab at 6 months, about a quarter of individuals go into complete remission. Now, despite rituximab showing promising results in early to intermediate stages of treatment, there is no evidence yet that rituximab can prevent kidney failure, and that can happen only with cyclophosphamide-based treatment, because those patients have been followed for more than 10 years, and there are at least 2 or 3 trials that have shown that cyclophosphamide and steroids prevent development of kidney failure. So this is how the current risk-based initial treatment of membranous nephropathy would look like. So we need to do risk evaluation according to the criteria that I had shown you in one of our previous slides. And important to emphasize that this risk stratification is not a one-time process. It should run, of course, at baseline, but it should be repeated periodically, specifically at 1 and 3 months. And during that risk evaluation, you look for if there has been any thromboembolic event, because that pushes the patient into very high risk category, the duration and magnitude of proteinuria, eGFR value, and again, urinary low molecular weight protein, as well as anti-PLA2R levels. If the risk level is low, then we wait and see. If the risk level is moderate, then we have these three choices. We can continue to wait and see if that seems to be the most appropriate course for that individual, and the patient is also happy with that, or we can decide to go with either rituximab or CNI in this situation. If the risk level is considered to be high, then the choice is between rituximab, CNI, along with rituximab, or cyclophosphamide and steroids. Whereas, as I said before, if the risk level is very high, then cyclophosphamide plus steroids would be the way to go. And some people have suggested using high dose rituximab in this situation as well. Now, the other thing that the new KDIGO guidelines is recommending is to reduce the wait and see period to 1 to 3 months in those with high or very high risk category. The next question that we are often confronted with and asked frequently is, how does anti-PLA2R level guide treatment? So now we know that the high PLA2R levels are associated with a lower rate of remission, both spontaneous or induced by immunosuppressive treatment, as well as a higher risk of development of nephrotic syndrome in those who are non-nephrotic to start with, and everyone is at a greater risk of kidney function deterioration. If immunosuppressive treatment is started, they often take longer time to undergo clinical remission. So the recommendation now is to perform longitudinal monitoring of anti-PLA2R antibody levels at least 6 months after start of therapy to decide what the treatment response has been and to guide further adjustments to therapy. And this is a particular approach that we are suggesting in the guideline. How do we adjust treatment according to anti-PLA2R territory? So let's say the patient has been treated with one of these treatment regimens. At 6 months, if the anti-PLA2R antibody level is absent, which means less than 20, then if the patient is on rituximab, you stop it. Cyclophosphamide, prednisolone, again stop. And CNI, of course, you cannot stop abruptly, but you should taper it off over the next few months. If the level is decreased, but less than 50, but not less than 20, rituximab, it might be worthwhile to continue with 2 more grams. Cyclophosphamide and prednisolone, at this point, you stop and watch, because we have shown, and others have shown, that patients can continue to enter remission for about as long as 18 to 24 months. And the anti-PLA2R antibody level also comes down. If the patient is on CNI, then continue it for at least 6 more months. But if the level continues to be high, if the patient has received rituximab, you can reinfuse 2 grams. Cyclophosphamide and prednisolone, you can stop this and add rituximab at this point. CNI should be tapered and replaced with or supplemented with rituximab and cyclophosphamide at this particular point. Now, although we recommend, the guideline recommends measurement at 6 levels, some centers will measure at 3 months also and stop stop if the antibody has become completely absent right at 3 months. And it's really important to also emphasize that so far as immunological response is concerned, if the patient is being treated with rituximab, in most instances, you will see responses in the first 3 months. That was clearly shown in GEM-RITUX trial and many other trials as well. Now, data has now become available, which shows that PLA2R antibody and serum albumin levels at 3 months are good predictors of response. So you can see the ROC curve here, and you can see the ROC curves with 3 models. One looks at the baseline level of anti-PLA2R and the clinical variables. The second one at 3 months, and the third one at 6 months. So you can see clearly that the 3-month and 6-month lines are clearly superior to the one at baseline. So this data is based on 96 patients who were recruited in the Mentor trial, where this analysis was done using a logistic regression model. And here is another study which looked at the probability of remission based on the high versus low anti-PLA2R level at baseline, and again, high and low anti-PLA2R status at 3 months. You can see that baseline high versus low level was unable to differentiate patients who are likely to undergo remission, whereas the 3-month level clearly differentiated people who underwent remission. So these are the people shown in dashed line here, no anti-PLA2R antibody level at 3 months, and those who continued to have significant anti-PLA2R antibody at 3 months had a lower probability of entering into remission. So what next now? And we take inspiration from Lord of the Rings again, because around the corner there are new approaches. So we have a secret gate or a new road that we are looking for in our quest to improve outcomes in these people. And one of the things that is much more likely to be tested in clinical trials relatively quickly is this new anti-CD20 molecule called obinutuzumab. And this is something which I know that it's under development. So with that, now let's move to looking at complement. The role of complement in membranous nephropathy has been known for a long time. This is a paper in 1980, which says it's a new role, but now we are in 2022. So it's now known for more than 42 years. Again, you can recognize some stellar names: David Salant, William Kauser, Michael Madaio, and so on. At that time, they showed that the use of complement depletion by cobra-venom factor reduced glomerular antibody binding and proteinuria in a IgAN and nephritis model of membranous nephropathy. Now we know that the IgAN and nephritis model of membranous nephropathy has a different antigen, which is not the same as the antigens we now know are responsible for development of membranous nephropathy, but this was one of the first, and complement staining is shown consistently in biopsies of membranous nephropathy. Now, fast forward to just a few days ago, this paper appeared in JASN, which looked at complement receptor activation and podocyte injury in membranous nephropathy. So what did they find? They found that in patients with membranous nephropathy, plasma C3a levels were increased. These patients exhibited strong expression of C3a receptor, and the plasma taken from these patients increased PLA2R expression and induced injury in podocytes in vitro. And both of these effects were reduced with C3a receptor blockade. They also looked at the IgAN nephritis membranous nephropathy model, and they showed that there was an increase in plasma C3a and podocyte C3a receptor levels. C3a receptor antagonists reduced proteinuria and glomerular injury. And again, these antagonists reduced C1q, factor B, and the membrane attack complex deposition. When they took plasma from experimental rats, they showed that this plasma also, just like the plasma for patients with membranous nephropathy, upregulated the C3a receptor on rat podocytes in vitro and caused cell injury, which was prevented by C3 receptor blockade. Now, I'd like to draw your attention to the fact that in most patients with membranous nephropathy, especially PLA2R antibody associated membranous nephropathy, the IgG subclass is IgG4. which we know that does not activate complement in the classical way. So that takes us to, and this is now something which we have known much more recently, the lectin pathway, which Professor Heather Reich described so well. And this is something which we did not know when the initial studies of membranous nephropathy were done. The human nephritis model in 1980 that I showed, this pathway was not known altogether. But now we know that it is likely that this lectin pathway is much more strongly responsible for tissue injury in patients with membranous nephropathy. And this paper, which was published last year in JCI, showed this really nicely. The way lectin complement pathway is activated in anti-PLA2R associated membranous nephropathy. So they showed that the IgG, which is present in these individuals, is underglycosylated, and that IgG4 predominant alloimmunization is of course seen against anti-PLA2R, and they showed that there is a proteolytic degradation of synaptopoietin and dynamin and Nef1, and the culprit molecule is this serine protease, which is associated with mannose binding lectin, and there is a very, very strong interest now in blocking this MASP to prevent tissue injury in patients with membranous nephropathy. And therefore, now Dr. Keritz and Schreiber propose that complement is not only a disease mediator, but also a possible treatment target. Because you can see that these are the antibodies, and this is on the blood side, and this is the endothelial cell that cross over to the glomerular basement membrane, where of course there is this serine protease, which is part of the lectin pathway. So the antibody binds to PLA2R receptor, and there is activation of this, and if we can inhibit this, then this becomes a treatment target. Another treatment target is by inhibiting the C3a receptor. So there is interest in use of C3a receptor inhibitors also in abrogating tissue injury in patients with membranous nephropathy. Just like Professor Wright showed you, there is a significant interest now in complement inhibition in membranous nephropathy as well. The trial situation is not as advanced in membranous nephropathy as it is in IgAN nephropathy. Most of the trials are in phase 1A or 1B or 2, and you can see that these are the trials which are currently registered at the clinicaltrials.gov website. But then there are many other approaches which are being explored in patients with membranous nephropathy, which include the regenerative medicine approaches and many other ways to modulate tissue injury. And I won't go into the details of those. You can actually go to the clinicaltrials.gov website and amuse yourself. Therefore, in conclusion, last 10 years have been filled with remarkable progress in our understanding of membranous nephropathy. Improved risk classification, mainly by antibody monitoring, allows better tailoring of therapy in these patients. The current treatment options are relatively blunt tools. So therefore, we are constantly on the lookout for more precise therapies. And our improved understanding, specifically with regard to the role of complement, means that we are potentially at the cusp of an exciting new era of therapies in membranous nephropathy as well. I'd stop here. Thank you for all your attention, and we'll take questions now.
Thank you. That was a really wonderful series of talks from both of you, and we have a large number of questions. Due to space limitations, I'm going to try to group them together. And I also would like to tell who sent, very specific clinical questions that it's difficult for the speakers to comment on that type of a question. So I'm not going to take those into consideration. Because they would be of less general interest to the very high number of people that we have attending the webinar. So I apologize in advance about that. So I wanted to sort of look at different aspects that people have been wondering about. And I guess for IgA nephropathy, for Professor Reich, there's a lot of interest and curiosity because of all these new therapeutic options that are coming through the pipeline. And so there were quite a few questions about what you think may be the future for the for DAPA, for the SGLT2 inhibitors, if they will become part of the standard of care for IgA nephropathy, both in adults and potentially also in children affected by this disease. So I wanted to start with this question.
Thank you. I realized also I didn't weigh in on my approach for the sample patient, where what I would have done in the patient I described, who's close to pediatric but not quite, but in her 20s, is I would have treated her with corticosteroid, regardless of her ancestry. And then once that treatment is complete, added SGLT2 inhibition. So a couple of points. Firstly, the EMPA data should be available this year, and so we're going to have more data to support or refute nephroprotective effects. I am already impressed by using DAPA in my patients. I think they are an excellent addition to RAS blockade as a nephroprotective strategy. I don't think that there is a rush to start them within 3 months. The patients were older and had CKD. And so I think that that's where our data are. And I don't see a downside of waiting 3 months and then starting them. What we don't know is if I have a patient that's kind of borderline and I just get the proteinuria under 1 gram a day with SGLT2 inhibitor, is that good enough? I'm always worried that there's evolving pathology that we're missing or masking. So I think that's a consideration. And then it depends on the patient, their age, degree of CKD. As for pediatrics, I think it's going to depend on the degree of CKD, because with good kidney function, when is the right time to start? We don't know. The studies really were CKD based. So if the patient has CKD and has had an adequate shot at immunosuppressive therapy, by all means.
Great, so that's really, really helpful and makes a lot of sense. Actually, right as we were speaking, an SGLT2 question popped in for Membranous as well, and I thought it would be a nice segue. So for Vivek Jha, do you think that there is a role currently for these agents and for DAPA in membranous nephropathy adults?
Well, of course, there's a huge amount of interest now in SGLT2 inhibitors, and we would like to add SGLT2 inhibitor to the water in all our patients with glomerular diseases. But I have to say that we need to wait for data, just like Professor Reich said, that the EMPA data should be available. And I think we will know more once these data are available, whether SGLT2 inhibitors are useful in these patients. Having said all of this, even after these data become available, they will always remain hypothesis generating, because that was not the primary question asked in these studies. And we will need to think about doing more definitive studies to find the place of these agents in these conditions.
Yeah, I think that's a very wise consideration. Thank you for that. So continuing with therapeutic options for IgA nephropathy, of course, people also have a large degree of curiosity about when to use Tarpeyo. So oral targeted released budesonide in IgA nephropathy, so which patients to choose for this agent. And specifically, a couple of people also wrote when should they be considering this type of an agent in children with IgA nephropathy.
I'll have to make maybe a disappointing answer here, is because we need to have the published data. And I think I can't really comment too much until we see what's published. If we see that there is a beneficial profile with respect to toxicity compared to corticosteroids, and if we see favorable outcome data, I'm supportive, and extremely mindful of the cost difference. And I think that on whether you're talking on an international scale or on the scale of countries where there are public or private insurance coverage, it is still at a massive difference in cost. And so all of these need to be factored. And accessibility is going to be a major factor. And I think the same would apply whether we're talking about pediatric populations. I know officially I'm supposed to say it's not studied, not indicated, the label's not there, but that's true of all of these new products in pediatrics. I wouldn't see a reason that it should be different. The only other thing I would caution is that they didn't include patients with vasculitic phenotype, which would be higher frequency in kids potentially. And so we don't yet know.
Okay, great. Thank you so much. So I wanted to move on, and then we'll come back to IgA, but give a little bit of space to the membranous nephropathy questions because there are really many coming through. And moving more to diagnostics and how to use those to guide us for therapeutics. A lot of people are wondering about PLA2R antibodies, and there are two sort of thought-provoking and I think important questions that have come through that have been repeated more than once. The first one is how to monitor the percentage of patients who are PLA2R negative. And so what should be the most reasonable approach in, going down the line of the risk definition in these patients? And then I'll tell you the second one after, so I won't confuse you.
Right, thanks. So I apologize that I limited my my discussion to anti-PLA2R associated membranous nephropathy because of time constraints. But of course, there is a significant proportion who are not anti-PLA2R positive, and we have to manage them as well. So if you, the risk stratification is mostly based on clinical criteria which do not include anti-PLA2R. So the risk stratification still remains valid in all of those individuals, and the decision regarding treatment approach will apply in the same way. I think where we will be limited is in our ability to monitor those individuals because we don't have any levels to follow. And therefore, we come back to monitoring of proteinuria and serum albumin. There is some evidence which is emerging to suggest that the serum albumin might be actually a very strong predictor of how these people behave in the long term. I think there is no change in the recommendation with regard to monitoring of these individuals based on those criteria if they are anti-PLA2R negative.
Great, thanks. And another question that came through that I think is, it nicely ties into one of our main objectives of these webinars, which was to also focus on complement inhibition, that I thought was a very good question, came through asking if you think that in clinical trials, which will be performed or are being performed in patients with membranous nephropathy with complement inhibition, is there a role for monitoring of anti-PLA2R antibodies to monitor response to treatment? I thought that was a very cool question.
Yeah, no, indeed. So, of course, when we are using complement inhibitors to treat membranous nephropathy, we are bypassing the initiating event, which is anti-PLA2R. So intuitively, one would think that monitoring anti-PLA2R antibody levels will not necessarily help us guide treatment with regard to anti-complement therapy is concerned. But I think we still need to be mindful of the natural dynamics of antibody development. So there will be still some value in monitoring the antibodies, though not in tailoring therapy that we will give potentially is the way I would think. But of course, we haven't done this yet. And so all this is entirely hypothetical.
Yeah. Thank you so much. And I'd like to segue on that, also still asking you a final question also because we're running out of time, and then I wanted to have a few more minutes to ask Heather another question as well. So In terms of the role of complement in membranous nephropathy, what do you think the importance of the IgG subtypes, so IgG4 versus IgG1, is in defining in a specific patient the role of complement? And do you think this type of a monitoring can be of use in selecting patients for a complement inhibitor trial in membranous nephropathy?
Right. So thanks. That's a very good question. And as I said, the IgG subclass does assume importance because a majority of these patients, especially with the anti-PLA2R antibody positive membranous nephropathy, have IgG4 as the subclass. And now we know that the IgG4 subclass is associated with activation of the mannose binding lectin pathway. And so these are the patients who will potentially be more suitable for therapies that target that specific pathway, as opposed to those who are IgG1, who have IgG1 deposits. It would be unlikely that those patients will be suitable for the mannose binding lectin targeting therapies, and we may need to consider other therapies. For example, the neutral endopeptidase associated membranous nephropathy, it has IgG1 as the predominant deposit, and I think you are best placed to answer that question, Marina, because you have worked on this and you have shown that potentially increasing the expression or activity of NEP might be the appropriate treatment approach there.
Mm-hmm. Great, that's really helpful. Thank you so much. So I wanted to move the complement question also to Heather Reich now, and wanted to ask, there's a lot of interest and a lot of different options now to inhibit different parts of the complement pathway in treating patients with glomerular diseases. And what do you think is going to be the role of these complement inhibitors in IgA nephropathy? Sort of what is your vision moving forward? What do you think are the patients in which this type of a therapeutic approach might be most beneficial?
Thank you. So it's interesting because, of course, in IgA nephropathy, we have some experimental models, but they're not quite to the same degree of similarity, I guess, to pathogenesis as in membranous nephropathy. And so I feel like we have, we're really going to depend on the outcome of these clinical trials to understand. So our understanding is really going to come from the patient and then inform our biologic framework about the relative role of complement. And so I really hope that these studies are successful, whether they're effective or not, but because they are going to offer a lot of to us in terms of understanding in the absence of a wealth of experimental data leading up. As to which patients, I have to mention a subgroup of patients where these are not being studied, but I would love to see, which is recurrence of IgA post-transplant, because we're already giving steroids, calcineurin inhibitors, and cytotoxics with Myfortic, and they still get recurrence of IgA nephropathy. So clearly we need a drug with a different mechanism of action. I would love to see it studied in that context. It's a hint for anyone who's watching. And the other, I think, in also the vasculitic disease, we see complement. And so that's another unmet need, albeit getting into ultra rare category. Into the run-of-the-mill IgA nephropathy, if we can spare toxicity and still get benefit, it should compete with our other immunosuppressive therapies. And I think it's nice also that we have, there's quite a bit of redundancy in the complement system, and it's nice during a pandemic that, to have availability of a drug that, so far as we know, may have at least different effects. We don't know in detail yet, but may have different effects in terms of susceptibility to other infections.
Yeah, thank you so much. So I think that's pretty much the end because of time limitations. And I think you both really wrapped it up nicely and sort of indicated in, for both diseases that it's, the availability of more therapeutic options, especially if they have a really good safety profile, is really what we need for these two categories of patients moving on. And that's why performing these studies, not only the complement inhibitors, but all the new studies, the new therapeutic agents that are being evaluated is so important. And we all need to collaborate to help these studies progress and be successfully completed. So on that note, I'd really like to thank all of the people who connected and our great speakers. I think this was an absolutely fascinating webinar. Thank you so much for participating and for your attention. And I'd obviously like to thank ISN and KDIGO for making this possible. And thank you all, and have a lovely rest of the afternoon wherever you are, or of the morning.